shooting के दौरान I suffered a massive.
Without taking much time, I would like to invite our today's session moderator, Dr. G.C. Khilnani, sir. Sir, although does not require introduction, sir is a chairman, PSRI Institute of Pulmonary Critical Care and Sleep Medicine. Sir was a formerly professor, head, Department of Pulmonary Critical Care and Sleep Medicine at All India Institute of Medical Science, Delhi. So welcome, sir. I request sir to please start the session, sir.
Thank you, Mr. Lakshman. Ladies and gentlemen, good morning to you. So, good morning, ladies and gentlemen. It's my privilege to be standing before you on a Sunday, and thank you very much for coming. This this program is especially very important for me as a learning exercise. One, because we have the topmost asthma experts, Dr. Vikram Jaggi, Dr. Chabra, and my colleague Dr. Pavan Tiwari is there. But more importantly, in the outpatient, we keep getting confused between whether this patient has allergic rhinitis, why, what should be done, should I refer this patient to the ENT specialist, what is the relationship? Frankly speaking, little confusion is there in my mind also, and we have three top ENT specialists who are with us today. And we are looking forward to have a very vibrant discussion. First, we'll have two sessions by Dr. Vikram Jaggi and the ENT specialist, and then we'll break for a panel discussion where we'll actually involve all of you. So, as a customary to give importance of the subject, that 300 million people around the world have asthma, and it's not that it doesn't kill. 1,000 people are dying with asthma every day. And most of these deaths occur in low and middle income countries, and majority of them are actually preventable. If you talk about the burden of asthma as per the Global Asthma Network Phase 1, that is 2015 to 2020, 9.1% of children, 11% of adolescents, and 6.6% of adults have a tendency for asthma. And even in these diagnosed patients, all over the world, the daily use of inhaled corticosteroids is less than 10%. And that actually speaks for the awareness on the part of doctors as well as the patients. And more than 25% of the patients are hospitalized at least once in a year, probably due to inadequate treatment. And there was a news item several years back, class 9 students dying with asthma, girl dies of asthma attacks, and parents blame school. That means that young person, there's a potential. And can you imagine in this 2024 or in this century, people dying with only asthma, healthy people dying with asthma. So so 334 million asthmatics, 250,000 dying annually, 80% deaths in developing countries, and 2 out of 3 deaths are preventable, probably more. Another disturbing thing is that oral corticosteroid use is seen in 89% of cases, and there are several exacerbations they have, mainly because of the inadequate treatment. Of course, we have come a long way. In India, the life expectancy was 32 years when we became independent. Today, we are at 72%. But as far as asthma is concerned, the inhaled steroids came in 1972, and then LABA and LABA ICS combination, and all these things we'll be discussing. But biologicals have come, and we were discussing just before few minutes back with Dr. Chabla and Dr. Vikram Jaggi that if properly used, the biologicals will be required for very minuscule of patients. So that we'll discuss during our panel discussion, and of course anti-IL-5, IL-4, and all those things have come. So what do we want to achieve? At the end of this 1.5 hours of deliberation, we want to achieve that we want to reduce impairment. That means there should be no attacks, should be no emergency visits, optimization of lung function, and normal daily routine activities. We also want to reduce the risk of exacerbation and prevent loss of lung functions in adults. So it's not that there's no evidence for this. There are several celebrities like Mr. Kashyap, who was a gold medalist, like Christie, who was an ice skater, and Bandit like Beckham, footballer, who was an asthmatic. Alan Border, everybody knows. And this young boy, being asthmatic, he actually conquered the Everest. So sky is the limit when you have asthma. So giving an introduction of why we are meeting with our ENT experts today. And I will emphasize that. And this is the worldwide prevalence of asthma. This is the median. In Europe, 19%, in America, 9%, Asia, 15%, Africa, 10%, Oceania, 38%. So it's staggering, 20%, 30%, up to 60% population in some countries have allergic rhinitis. So what is the relationship? How does asthma and allergic rhinitis? So 87.5% of patients with allergic rhinitis could be having asthma in some studies, chronic sinusitis, otitis media, and recurrent nasal polyposis that we'll be discussing. And why this commonality of concordance of something like 87%? Because anatomically upper and lower airway are contiguous. They have a similar histology as far as the mucosa is concerned. There are same triggers like house dust mites or pollens or pet denders, molds, and so on and so forth. Same mediators of inflammation like Ig, histamine, cytokines, leukotrienes. Same cells, mast cells and eosinophils. So allergic rhinitis, asthma, and sinusitis, they have a close relationship. Now the patient is only one. You can't be treating only allergic rhinitis, leave asthma, and vice versa. Or there may be underlying sinusitis you cannot ignore. So in the interest of the welfare of the patient, we should understand all three components. Then only you can give a meaningful care. And the drugs are also similar, whether anti-IgE or steroids or antihistamines or anti-leukotrienes. So evidence and mechanism of nose and lung interaction is very important. So therefore, the treatment of allergic rhinitis improves asthma symptoms, decreases in AR, that is allergic rhinitis asthma symptoms after intranasal corticosteroids. Leukotriene antagonist effective on both, and immunotherapy we'll be talking about briefly. That is also effective for both. So there is a lot of commonality. And frequently the patients come with chronic cough for months or years together. And we keep wondering whether it is the cough variant asthma or this cough variant rhinitis, or when the asthma and rhinitis may appear worse than it is, cough may be misattributed to asthma and so on and so forth. So just want to emphasize why we are together today. And we have an amazing schedule up for a very, very good discussion, and for which my pleasure to invite Dr. Chabda. Caller mic दे दो कोई बात Am I audible now? Better? Yeah. So my pleasure to invite Dr. S.K. Chabda. Currently he is at Primus Hospital, but for all his life he was professor of respiratory medicine at VP Chess Institute, and he was actually professor of respiratory physiology. And I know his expertise in asthma also, and so we'll utilize his expertise. It's a pleasure to invite Dr. Chanchal Paul, please come on the dais. She is a senior consultant in the ENT department at Indraprasth Apollo Hospital, New Delhi. Dr. Girish Raheja, he is also at the Apollo Hospital, a senior ENT specialist. And last and not the least, Dr. Pawan Tiwari. I had the pleasure of working with him for 10 years at AIMS. He did MD medicine from AIMS and then DM in pulmonary critical care and sleep medicine. At his young age, you can see he has, I think, about 300 publications. And very unassuming person and has worked a lot as an intervention pulmonologist, as a person who works in the air pollution, done a lot of research work. So uh, I'll be making it as interactive as I can, and if you, all of you, and I'll be involving my friend Dr. Vikram whenever there's a difficult question. So 21-year-old girl, she has history of allergic rhinitis since childhood. Currently no significant symptom related to the nose, but she recently shifted to Delhi for studies as happening these days. She has episodic dyspnea and wheezing for last 2 months, predominantly in the evening and early morning symptoms, frequent night awakening, recent upper respiratory tract infection which is improving, but respiratory symptoms have increased. As partial improvement in symptoms with over-the-counter medication like cough syrups and anti-allergic drugs. She has history of asthma in her mother, and clinical examination as bilateral polyphonic wheezes, and PFT is normal. So this is the case before us, and this is not very unusual. We do a lung function which is normal. So first I come to Dr. Chabla. So how do you suspect in the patient asthma who comes with allergic rhinitis, his PFT is normal, but he is coughing or whatever, the symptoms are right in front of you.
Now,
So please keep it close to your.
if we look at the history of this patient, she had a long-standing history of allergic rhinitis, which had decreased over the last few weeks or months, and now she has started having episodic dyspnea with wheezing, and which is sometimes coming up at night, early morning. There's a family history of asthma, so this is almost a very classical presentation of asthma. Begins with rhinitis or sometimes atopic dermatitis, which subsides, and then asthma symptoms start. So history is the cornerstone of diagnosis of asthma. We can have PFT normal because asthma is an episodic disease. So even PFT is an episodic problem that there will be airways obstruction at some times and it will be normal at some time. So having a normal PFT does not rule out asthma if the history is a history of asthma. So in this patient, considering the history, remains allergic rhinitis with bronchial asthma. Currently, the patient is either having a very mild asthma or is in remission.
So
Because
Dr. Tiwari, if I could come to you. So should we make a clinical diagnosis of asthma or wait for PFT or other ancillary reports or keep it close to your.
Sir, by and large, asthma remains a clinical diagnosis. So whatever laboratory investigations or spirometry that we do will only corroborate our diagnosis. Or let's say we want to demonstrate objectively that there is reversibility for us and for the patient. So it is more of an ancillary test rather than a diagnostic test. So somebody who has clinical symptoms and it fits into your diagnosis of asthma, make a diagnosis of asthma and start treatment rather than waiting for PFT or using PFT to say no, she or he does not have asthma.
So well said. So Dr. Girish, in your practice, when do you think that person has come with florid allergic rhinitis? When do you think he has asthma and you refer it to or whatever?
So I fall back on data. I know that a very large number of these patients, even if they are not complaining, would possibly have some hint of asthma. So if I want to just diagnose whether there is active lower respiratory tract allergy or asthma, I would probably send for a PFT with a bronchodilator. In my hospital, it's easily done. I would definitely fall on history because that's going to be the cornerstone. You need to spend a little time. And if certainly the patient has an early morning cough, a late evening cough, and there is some history of allergy in the family, I would suspect that he has some amount of asthma, maybe very mild. And some of the talk today has been on how to convince the patient. A lot of our patients are educated. They do react better if there's evidence in front. So if we have to follow evidence-based practice, as far as the patient at least is concerned, if we have the evidence, then it is slightly easier to convince the patient to try a medicine. And as he gets better, that's a positive feedback. But I would strongly suspect it in fair number of my patients.
So, as our data showed in my introductory, 87%. That's staggering. So, wheeze, shortness of breath, chest tightness, of course, these are the symptoms. But if you want to document airflow obstruction, FE1 upon FVC should be less than 0.7 at least, and zero point 0.9 in children. And excessive variability in lung function, that is FEV1 reversibility of over 4 weeks time, you should repeat a lung function test. And if there's 12% increase or 200 ml increase in FEV1 and weekly average diurnal PFR variability of more than 10%, I don't believe much. Do you believe, Dr. Chhabra, in peak expiratory flow rate, which is close to
In India, although in some of the Western countries, and definitely GINA advise its use, but it's not a popular instrument.
so FEV1 upon FVC ratio has limitation in diagnosing obstructive airway disease. Population specific normal values upcoming in India. Now we are seeing, and there's poor correlation of peak expiratory flow rate with FEV1 for the diagnostic purpose. So this should be understood. So test can be repeated during symptoms or early morning or later on. So Dr. Tiwari, how should one initiate treatment for a recently diagnosed asthmatic patient? What parameters you will take in?
So the
I
basic
think that panel discussion is simple. I'll make it more complicated as we go. Yeah.
So the first thing is that I mean inhaled corticosteroids, low to moderate dose of inhaled corticosteroids steroids are the sheet anchor of treatment. First thing to do is to always keep inhaled corticosteroids in mind. The other thing is it will depend upon the extent of symptoms that the patient is having, whether they have a nighttime awakening, significant respiratory symptoms, or whether they are in exacerbation. That will then decide whether you will add a long-acting bronchodilator, a beta agonist, or subsequently add other therapies also. The other thing will be to add treatment for comorbidities. For example, people who have for example, it has been discussed in detail in previous talks. If they have allergic rhinitis, then that has to be treated. If they have reflux, then that has to be treated. Basically, low to moderate dose inhaled corticosteroids along with long-acting beta agonists on a regular basis, along with as needed basis, and treatment of comorbidities. That will be the initial guiding thing for
So,
starting treatment.
Dr. Chabra, the 2024 guideline have dumped SABA, short-acting beta-2 agonist, as a initial, as we were preaching for last 30 years that give salbutamol 2 pods or 4 pods or nebulization while stage 1. Now they are saying that give inhaled steroids along with this as a SOS. So what is your take?
See, what has happened in last few years is that there is a sea change in our approach to pharmacotherapy of asthma. And Gina summarized that very well. Now it has given two methods, one called tracks 1 and track 2. And track 1 is the recommended method, which is that you use just one inhaler for both maintenance therapy and for reliever. So that is a big change in concept. That earlier we were using inhaled steroid as a maintenance therapy and salbutamol as the reliever. So now salbutamol, if you're going to use track 1, practically becomes obsolete for asthma. So the same inhaler, which is a combination of inhaled steroid and a long-term beta-2 agonist that works as a maintenance therapy and as a reliever. So that anti-inflammatory reliever therapy, that is a change. And this works very well. There's enough evidence that if you use the combination as a reliever, patients have fewer exacerbations, less hospitalizations, and less adverse effects compared to use of salbutamol alone. So that is why salbutamol alone went into disrepute because of increased risk of exacerbations.
So what is the difference between the track 1 and track 2?
So track 2 is that if you are unable to use the same inhaler for both maintenance and reliever, firstly, and that will be for very, very few patients. So track 2 is another combination of inhaled steroids and a long-term beta-2 agonist, like a vilanterol or fluticasone or salmeterol fluticasone, plus salbutamol as the reliever. So that is a standard therapy which we had been using before 2019. So that is track 2 for a few patients who are somehow not able to tolerate or don't want to take the single inhaler. For majority of patients, track 1 is the norm now.
And formoterol is the common.
Formoterol and budesonide combination now is practically the, you can even say, the first line treatment of asthma now. There are alternatives available, but this is by and large the most popular combination.
Because the formoterol is long acting as well as
And this,
rapid acting.
and one more point, this is the only combination. You know, there are other combinations of inhaled steroids and LABAs available, but they are not to be used in track 1. Only budesonide and formoterol can be used in track 1.
But it
This
says
is very, very important point.
Sorry, it says low dose ICS plus formoterol.
Yeah,
Gina
because
doesn't
other
say-
LABAs like indacaterol or vilanterol, they are not to be used as SOS
The
medication.
question is budesonide is the sacrosanct, or you can use fluticasone and
Fluticasone and formoterol
yeah.
is an
So
alternative.
Gina doesn't say use budesonide, but Gina does write formoterol
Yeah,
as a
So formoterol is the key
key.
drug.
Is the key. All right. So this patient was started on LABA and low dose ICS. So we go ahead with this case, and this is a table which cannot be read, but give the dosages of what is called low, medium, and high dose of corticosteroid. The value will come as we go ahead. So this concept of anti-inflammatory reliever therapy, that is called air therapy, and benefits Dr. Chabra has already described. And so we go, the term AR is added in track 2 based on the Mandela study, which has actually shown distinct benefit. Also, there is a Sigma trial. I don't have time to go into that. Then these trials have actually made the GINA people to say that use AIR therapy, that is anti-inflammatory reliever therapy. Now, what is the difference between AIR and MART therapy, Dr. Tiwari?
So basically, the only difference is that one thing is this therapy is being used on as needed basis. So
What is MART?
MART would be a basically single inhaler being used for maintenance as well as for reliever therapy. So maintenance and reliever therapy in single inhaler, the like Dr. Chabra sir had already told. For example, formoterol and budesonide. So it can be used twice a day and then in between as needed. So that would qualify as MART therapy. Now the same thing can be used as anti-inflammatory reliever therapy also. That means we are not using that drug on daily basis or regular basis, but as and when the patient gets symptoms, instead of taking only a short acting bronchodilator, the patient takes a rapidly acting bronchodilator along with a low dose steroid. So what it does, it is basically, this is for patients who are having mild asthma and are not keen on taking daily inhalers. So what will happen is, if a patient has symptoms, then he or she will take rapidly acting bronchodilator, but along with that, they will also take a inhaled steroid. So it acts on inflammation as well as on symptoms. So the idea being that it will relieve symptoms, but it will prevent a lot of severe exacerbations. Though these patients are not at very high risk of having severe exacerbations, but overall as a population-based risk, it is thought that this AIR therapy in patients who are not regularly on treatment or who are not compliant to treatment and have mild asthma, it will prevent a lot of severe exacerbations. So it will reduce the population risk of severe asthma and poor outcomes.
So at this stage, Dr. Vikram, your Your take on AIR and MART?
So,
Any
it is,
reservation?
yeah, so it is essentially
Keep it
the
close
same
to-
thing. The nomenclature is how it is to be used and which situation. So MART means the situation that it is used for a maintenance. When we are using the word AIR, it is how it is acting and it can be used for SOS use. That's the only difference. The composition of the two is essentially the same.
So, Dr. Chabra, coming back to you with a little difficult question. The inhalation device is always a question. Some people are comfortable with DPI. Some people, as Dr. Vikram said, that nebulizers are overused and abused actually for the ease. Because when you take Asthalin tablet, then you feel something is going into the system. Sometimes also we physicians feel कि elderly है 60 years, 70 years, 80 years, चलो nebulization दे दो, कुछ तो जाएगा, he'll definitely get it. So when you, in this particular patient or a young patient, how do you decide the device?
Uh, Dr. Jaggi has discussed this very beautifully in a very practical way. So broadly, we have got beta dose inhaler with or without spacer. We got a dry powder inhaler system, and we have got a nebulization. And this patient, who is a 21-year-old lady, the use of a nebulizer will practically be out of question in this patient. Because nebulizer, home nebulization for a very select group of patients, like very elderly who cannot use a meter dose inhaler device, or who are so debilitated that they cannot generate enough, for which applies more to COPD actually than to asthma. So that is a very small select group. Now, for most patients, the choice is between a meter dose inhaler and a dry powder inhaler system.
Tell me,
A dry powder inhaler system and meter dose inhaler system are equally effective. Ultimately, it depends on which device the patient is able to master well. So if a patient is comfortable with meter dose inhaler and spacer, I'll use that.
So-
Or if the patient is comfortable with a DPI system, I'll use that. So there's, as far as efficacy is concerned, there's no difference. It's how the patient accepts it and how he uses it and masters the technique that is more important. So in this lady, the option is either a dry powder inhaler or a meter dose inhaler with a spacer.
So this is a young girl, young lady who is actually a very qualified technician at AIMS. So she was taking inhaler like this, and you tell us whether it is rightly or wrongly she is taking.
I think what she did was she took her inhalation first and then actuated the inhaler.
So there's always some problem with this kind of. So
Actually, there are uh, scoring systems available, and there are actually 9 or 10 steps where you start your breath, how deeply you inhale, breath holding. All these are very important steps. So this is part of patient education, and time spent on this is time well spent. And when a patient comes back on follow-up, generally we recheck the technique to make sure the patient has followed the instruction. Because a lot of patients make silly mistakes. They'll either hold the inhaler upside down, or they'll first breathe in and then press the inhaler, or they're breathing out and then pressing. So all kind of mistakes are
Okay.
there.
All right.
When you ask the patient to take in front of somebody, you can actually see the puff coming out. So these mistakes have to be corrected. Once corrected,
So,
then the option is
Dr. Chabda, over a period of time, if I could give my thought process, I have stopped giving inhalers with the technique that we saw, without spacer, because actually hardly anybody can take it properly. I mean, that's my personal take, and I always give spacer. Now we are the low volume spacer are good enough to be kept, and of course they are breath actuated and things, there are fancy things one can use it. So getting back to this 21 years old girl, patient returned after 3 weeks, minimal relief in dyspnea and chest discomfort, persistent nocturnal symptom as morning sneezing with nasal stuffiness. So So, Dr. Chanchal, I come to you. Do DNS and sinusitis worsen asthma, and how should we manage this?
Yeah, true. DNS and sinusitis. This patient should be sent for nasal examination. And DNS, what does DNS does? Levitin nasal septum, apart from obstructing the sinuses and causing sinusitis, it also obstruct the free ciliary flow, nasociliary flow from the nose, and it comes out down to be a thick viscous. It becomes viscous and goes as a postnasal drip. And sinus, of course, also postnasal drip, and it is the same inflammatory process. So treating both will help to control asthma better.
So, do you think that when do you think that you should tell them to undergo your knife, do a surgery for DNS?
See, the deviated nasal septum is a very, very common thing. Almost 25 to 30% of the patient will you will see when you do their medical examination. So not everybody has to go under our knife. But when you're seeing the deviated nasal septum is obstructing airway, or it is obstructing the sinuses and are not allowing sinuses to have a free flow, nasosinus clearance is not there. Nasociliary
So, the
function is.
think it will improve.
Yes, definitely. Dealing with the deviated nasal septum will help better control of asthma and, of course, nasal airway.
Dr. Grish, your take?
I first object to the fact that you club them together, sir. Sinusitis is a
No, no,
inflammatory
no, no, wait a
infected.
minute. I am not club. I am only discussing DNS. I am coming to sinusitis.
Okay. No, I'm allowed
I
to
I
argue.
want your comment
I'm
on.
allowed to put my point through, even with your seniority, sir. Anyway, the concept of upper airway resistance syndrome is well known to respiratory physicians. If you have significant deviated septum with allergic rhinitis giving rise to a stuffy nose, that means there'll be mouth breathing, and chances are asthma will get worse. So that's number one. Number two, anybody with a stuffy nose is likely to have some postnasal drip. Now, nobody knows how much it affects asthma, but certainly a postnasal drip is likely to cause laryngeal irritability, giving rise to spasmodic cough with or without a wheeze. Thirdly, uh, there seems to be no doubt that if you treat sinusitis well,
Ah,
after you document it and prove it, it will definitely have a beneficial effect on your control of asthma. Is one of the reasons for failure of therapy.
so, if I could interrupt you, sir. Uh, so, if you want to diagnose sinusitis, I'm telling you a little of my experience that that town's view of X-ray hasn't helped us. So, when do you actually go for a CT scan to diagnose sinusitis, or it's not necessary?
We don't get an X-ray done, sir.
You
So
know,
X-ray has 30 to 40% false negatives and positives.
so
It's a useless investigation.
no X-rays for sinusitis.
We can go if you're worried about irradiation. There's a cone beam CT available, very low radiation that we use in children. But I think
So
if
when would you actually say go for a CT scan?
if my patient is not better on medical treatment, so we don't normally rush for a CT. But certainly, if a patient is not getting better, or if a patient is referred by a respiratory physician, and the patient's asthma control is poor, then I might even do it on the first visit if I suspect significant sinusitis.
And if there is one, I mean, when we get the CT done, I'm talking about my little bit of experience that there is some mucosal thickening, and if there is of course air fluid level, then it's a different ball game. Then sometimes there is pansinusitis. So how do you our focus is asthma. So how do you correlate with them, and how do you manage them?
If there is mucosal thickening, that is expected, I would say, in a large majority of these patients. And they don't need a surgery, surely. They need just a better medical management for allergic rhinitis, provided they don't have significant deviated septum or something called a concha bullosa or other reasons for a definitely obstructive, static obstructive lesion in the nose. So I would only treat a sinusitis which is not resolving after 3 or 4 weeks of medical therapy.
And what is that medical therapy?
So if there are air fluid levels, I'll put on almost 2 weeks of antibiotic
Okay.
with a short course of intranasal decongestants and a long course of intranasal steroids. And
What is the role of steam inhalation?
pardon me, sir?
Steam inhalation, does it
I think it's quite useless.
useless?
But saline irrigation is very, very useful.
Okay, all right, Dr. Chavda.
Let me give a pulmonologist's perspective on
Yes,
sinusitis.
that's what the whole.
Because we see patients who have nasal symptoms, so we get the CT sinus done. Now, you mentioned mucosal thickening, so that is expected in allergic inflammation, so the patient is not referred for surgery. DNS is a major problem, and when the sinuses are clear and only DNS is there, DNS surgery is something which is very often patients complain that they went under the table, got it done, it didn't work. Because DNS and symptoms are not related. Allergic rhinitis symptoms are not because of
That
DNS.
Vikram has
So
already.
if DNS is not causing persistent obstruction, it is better left alone. If it is causing obstruction off and on, that is inflammation. So that is then again tackled by anti-allergic therapy like topical.
So Dr. Chanchal, Dr. Chanchal Pal, sorry. Which patient should undergo a sinus surgery?
Yeah, even I will talk about DNS when he said deviated nasal septum, if it is obstructing, the purpose is to have a clear sinus nasal sinus outflow.
Emphasize.
That should be very clear that we mucociliary clearance from the sinus is done when whatever is obstructing the sinus, if it is not medically getting corrected, you should operate. That means even if you deviated nasal septum, as Girish mentioned, concabulosa or enlarged turbinates, or osteometal complex blockage, or frontonasal sinus blockage, whatever is causing mechanical blockage, there we go for sinus surgery or deviated nasal surgery. The purpose is to make the mucociliary clearance and proper sinus drainage. That is even if you are dealing with the polyps, you are dealing with any mass there, the purpose is to clear. That is when we are fully satisfied that medical treatment is not going to help it, right on the day one after seeing CT scan or after giving medical treatment. So whenever we have their fixed criteria, when they fall in that criteria, you should go undergo. Not everybody has to go under the knife, but at the same time, do not stop those who need it to undergo the knife. Otherwise, the management of the lower respiratory ailments get bad.
Dr. Girish, your take. When do you actually tell them, okay, the surgery is required?
Certainly, if the symptoms are not getting better, you don't promise anything, but you do expect that if you improve the mucociliary clearance and the breathing and the filtration and the humidification, the function of the nose, the lower respiratory tracts react favorably.
And what about when there are large polyps? You can see, one can see it.
So polyposis is a different disease altogether. Polyposis is a disease. We don't understand why some people with allergies have polyps. And certainly polyps are reoccurrent and the patient needs to be aware about it. And if a patient has asthma with polyps and with aspirin sensitivity, uh, it's very likely that the surgery may not be very effective. The patient needs to know that they are difficult to help patients because of the modality of disease that they have inherited. But certainly removing the polyps, using intranasal steroids, encouraging them to come for regular follow-ups with every exacerbation so that we can help them in resolving the polyps with short courses of oral steroids if needed, seems to help, sir. There's no doubt that asthmatics do better when we remove polyps and
Oral steroids are used for polyposis also.
yes, of course, they definitely help in resolving polyposis. And in short courses, they can be used because once they resolve, let's say on an operated patient, if there's a reoccurrence, then the intranasal steroid starts working again, sir. But once they really become big, then the local steroid doesn't work.
I'll can I interject here? So I will tell you what we should tell the patient. I usually tell that polyps are because of three factors: infection, obstruction, and allergy. When you have this combination, then only. And no surgery will treat allergy. We should be very, very clear about it. Whatever you do, surgery is not going to treat allergy. We are going to remove the obstruction and taking care of the infection. So we'll remove part of it from the etiological factor.
It's good that you are very, very emphatic about it. Yes, Dr. Chavda.
On the subject of polyposis, there is a very, very important scenario in patients who have got asthma and polyposis that called Samter's triad. And I have seen two patients who just took aspirin tablet and they went on mechanical ventilator. So NSAIDs are contraindicated patients who have got asthma and nasal polyposis. One should be very, very careful. That's called Samter's triad, and patients can have near fatal asthma.
You agree?
Uh, yeah, allergy to aspirin is there, but we have not seen many cases. But you have this combination, you should be careful. And actually, when we are treating with allergic rhinitis, you should emphatically ask, do they have breathlessness? Sometimes they mistake that breathlessness to their nasal obstruction. So when they're climbing the stairs, when they have these problems, and when coming to polyps, yes, one treatment is of course oral steroid, short course of oral steroids. But after that course, if the polyp come back or they don't disappear completely, surgery is again recommended to reduce all the inflammatory process.
So I should not quote one of my very close friend who is a very senior ENT surgeon. Uh, he was very fond of giving PPIs to these patients, those who have sinusitis, and so anything, either of you is fond of giving PPIs or if without any symptoms of GERD.
Uh, GERD or LPR is very well known, and nowadays with the lifestyle changes, definitely we do, if we see unnecessary congestion and even up to the nasal ear retraction, TM retraction, nocturnal regurgitation is an important thing. So PPI is one of the things. Maybe we are overusing it, but at times it's useful.
So the
So
third
may I
question,
just
yes, sir.
add a small thing? So laryngopharyngeal reflux is a first cousin of GERD, but not really GERD. And almost 40% people have no history of regurgitation. They
Yes.
don't have a heartburn. So when we do a laryngoscopy and we find that with the other symptoms of the patient, if there is a retinoid inflammation, definite retinoid inflammation, a nice long-term PPI would help almost 70-80% people.
Okay. So there you are with my friend. Who
No, sir, he didn't mention clinical examination.
no, oh, I should have mentioned that. I should have mentioned that. So the third question is, what is the current status of allergy testing? That has been discussed at length by the Dr. Bhardwaj and also, so I am skipping that in the interest of time. And common disorders which are confused with asthma, you are all astute physicians, from cardiac failure to pulmonary fibrosis to vocal cord dysfunction. Very rarely we have actually diagnosed doing bronchoscopy, in these patients. You must be doing laryngoscopy to see vocal cord dysfunction, and actually I have not found any treatment for that. So getting back to this 21 years old girl who has repeat PFT did show actually airway obstruction of FE1 upon FEC ratio of. So now we have diagnosis of asthma on PFT also, but uncontrolled symptoms despite treatment. So Dr. Tiwari, what should we do next? We have given him inhaled corticosteroids, and what should we do?
So the first and foremost thing should be one compliance, and actually even more important will be the inhalational technique. So if that is being followed, then subsequently we can look at the severity of asthma, whether I mean she needs further treatment in terms of systemic steroids or even hiking the dose of inhaled steroids. But the first thing will be technique and compliance.
So this patient was actually not taking MDI properly. There was a coordination problem. Patient says sometimes when asymptomatic, she takes only one puff instead of two, and sometimes they actually miss their. And allergic rhinitis only comorbidity not addressed till now. Her total IG was 300 and Aspergillus specific IG was 0.01, which was normal. So what should we do now, Dr. Chavda? We have corrected the inhaler technique now.
Did we do a CT-PNS in this patient?
No, we did.
We haven't done.
We
But
did.
she has nasal symptoms, so definitely
Yeah,
we need to look at the sinuses in this patient.
next time when I do a panel discussion, I'll put it.
Right.
Okay.
So if so we have discussed the
Yeah.
aspects of nasal involvement which will require.
Three things. Increase ICS dose, add Montelukast antihistaminic or add theophylline.
Now she is on low dose inhaled steroid.
No, ICS.
Right now current dose, so we have to step up the treatment. So it will depend on whether she is on step 3 or step 4. So if she is on step 3 right now, that is low dose inhaled steroid and LABA, we'll go on to step 4, which is a medium dose inhaled steroids plus LABA, and see how she responds to that.
So what about Montelukast and antihistaminic?
These are step 5 drugs. All these drugs, Montelukast, theophylline, LAMAs, these are all
you agree?
step 5 drugs as per the current GINA guide.
Yes, sir. Basically, first will be to correct her technique. Then, I mean, we can increase the dose of inhaled steroids and probably add nasal steroids because she has allergic rhinitis.
So this answer says not right now. Patient re-educated on MDI, spacer technique and compliance to treatment. Low dose nasal steroids were added for allergic rhinitis and she had controlled asthma. So she didn't have to increase, only the correction of technique did that. No other symptom, feels energetic, able to exercise without discomfort. Symptoms of allergic rhinitis are also controlled. So very good. The treatment is very good. The question is, should we continue treatment or consider stepping down?
This is a question which requires a consideration of her history also. Supposing, like her, right now we are in July. August and September were bad months.
Sorry, my question is specific. That patient has improved, say, in 1 week's time.
Right.
Then do you continue the treatment or you say, okay, you have done enough? Step
No,
down.
the treatment will have to continue because the treatment of asthma is.
How long?
It depends on the patient's histories.
The GINA guideline.
If the patient has episodic asthma, then it is expected that after she recovers and attains the goals of treatment, we should be able to step down.
The history. So what will you do?
Now, again, I am coming down to her history. Supposing in the previous years, August and September were bad months, then it is unlikely that she is going to stop treatment in July. So she'll have to
what do you say?
And so once the objective of treatment is attained, that she should have a normal lung function, she should be free of daytime symptoms, nighttime symptoms for at least 3 months, then we start stepping down the treatment from step 5 to 4 to 3. And ultimately, if she has, because the periodicity of symptoms is very variable. Some patients have asthma only once or twice a year, some have throughout the year.
Okay.
So, sir, yes, correct.
So the GINA guideline says that you continue treatment for 3 months. That's the guideline, what it says. So step down treatment in asthma, GINA recommends stepping down treatment. Once good control achieved, maintain for 3 months and then step down. So this I finished with the case 1, which is a simple case. I go to little more complicated cases. If you have any question in the audience, please tell me. So case 2 is a 36 years old female, diagnosed case of asthma. She has chronic rhinosinusitis also. She has symptoms of GERD also. Has gained weight post-pregnancy and due to recurrence of use of oral corticosteroids. Has lost asthma control in last 2 years. Current BMI is 30.1 kg per meter square. 1 hospital admission, 8 exacerbations requiring hike of oral corticosteroid in last 1 year. On high dose ICS LABA with antihistaminics and steroid spray, oral Montelukast and levocetirizine and 5 mg of prednisolone per day with uncontrolled symptoms. So that's where we are. Now the question is, Dr. Chavda, how would you approach?
Now, this patient is what we label as a difficult to control asthma because she has plenty of factors. If you can go back to that slide, so that it will be easier to tell about the factors which require attention in this patient. Her chronic rhinosinusitis requires evaluation. So we will be taking help of our ENT colleagues, whether to Was any option of surgery is there, or use medical therapy for that? Because until that is corrected, her asthma will keep getting flaring up.
मतलब आप
Then
क्या करोगे ये बताओ फिर?
we'll look at the CT-PNS and see what it is showing.
Okay.
And the local ENT examination also, if there's any surgical correction possible or required or not, which we have discussed just. Then her GRD has to be controlled. So all the measures, medical measures, including bed position and all, and possibly a gastro referral if required. Then she has obesity. So I'll again ask whether she has symptoms history of sleep apnea as well or not.
So let me give you a little further.
Mm.
So his FEV1 was 58%, so it comes in the moderate. Absolute eosinophil count was 400, but on the previous occasion it was 900 to 1000. The total IG was 600. ABPA workup was negative. Obesity could be one of the factors affecting asthma, nasal polyps, bilateral maxillary ethmoid, could, and osteopenia she had osteopenia on DEXA scan. She also had vitamin deficiency. Dr. Tiwari, rather a complicated problem. What would you do?
So basically, she has a severe asthma and difficult to treat asthma, and as she has elevated IG and elevated eosinophil count historically, uh, one thing will be to, and she is requiring systemic steroids. Even on systemic steroids, she is not having controlled symptoms. So one thing will be to phenotype. I mean, we have already phenotyped her asthma and we have ruled out ABPA. So will be the next step will be to go to biologicals. The other important thing will be to take care of her reflux and the nasal polyposis symptoms. That will be medical or surgical.
So Dr. Chanchal wants to add something.
Here I like to mention, sir, that never go for CTPNS directly. Uh, Request for ENT reference. No, we know which stage we should go for CTPNS because you cannot repeat CTPNS again and again. So first should be nasal examination, and at times in polyps also we give medical treatment first and then ask, because we are seeing the polyp, we know the sinuses will be full of polyps. So we know which stage to get CT to decide whether this patient can go on medical treatment or we do have to interject as a surgeon. Here you have been giving steroid time and again. Probably that would be taking care of our polyps also. So this patient definitely will need a functional endoscopic sinus surgery here and correction of nasal obstruction. That will usually take care of most of the asthma problem rather than giving on biologic. First address, of course, there are three problems here as we can see: obesity, nasal and GERD. All three have to be comorbidity, have to be addressed for asthma treatment to be better, and better coordination between pulmo and rhino will help. Thank you.
Dr. Dr. Vikram, Mr. Dr. Girish first.
I think obesity should be the first thing addressed in this patient.
That's the
It's
most
likely
difficult.
to help.
She tried, she tried, but she could not.
Because these patients have obstructive sleep apnea also because nasal obstruction. So they are not very active with the nose block. And I've seen once you clear the airway, they can exercise better and they improve better.
I think what we've not discussed is the possibility of trying nasal douche. It's a very, very effective way in controlling some people who seem to be not having a controllable asthma and allergic rhinitis. It's worth trying, and it works and helps. I can tell you post-operatively, the reoccurrence rates have gone down dramatically with the use of nasal douche and the intranasal steroids.
Before that, you have to do surgery.
No, not necessarily. Jalniti was done in people without any reason actually, and I think it well prevented a lot of nasal
Cases
allergy.
of polyp, I'm saying. Cases of persistent polyp.
I mean, I would still
been able to generate a good discussion. So between the two otolaryngologists, astute otolaryngologists, there is a difference of that's what the. So Dr. Vikram,
Yes.
you treat most difficult cases. She has osteopenia, she has.
So her comorbidities have caught the attention of all the doctors. I would do two things at this stage. One, I would go right
Closer.
back and look at the inhaler
Keep
technique
it
and
close.
inhaler technique and everything, and make sure and not simply assume that it is being used properly. And two, in the light of a very high or moderately high IgE, ABPA having been ruled out, ABPA having been ruled out, I would still take the help of my ENT doctors for allergic fungal sinusitis. That also possibility I will look at.
So, yes, yes, please.
The environment where she is staying, because that is one factor that has to be looked into.
Sure.
That is
We are
very, very important factor. In fact,
coming to that. Coming to the triggers. So we have discussed the do DNS and sinusitis worsen asthma? How should we manage sinusitis? And which patient should be offered first? All these three issues we have already discussed. So what is the current state of allergy testing and immunotherapy? This also we have discussed at great length. So status of Montelukast and antihistaminics in allergic rhinitis and asthma. First I come to Dr. Chanchal. So how frequently you give? There was a black box warning. I guess you know that
Yeah.
in US, causes psychiatric disorders and so on and so forth, depression, and I in fact wrote on social media also about that particular study. So, and I, you and me, I think all of us know people taking this combination for decades now.
Yes.
They just get hooked to it. So what do you think about it?
So true, sir. And antihistamines, yes, definitely. Most of the time we have to give because that's the main factor which is happening in allergic rhinitis. But in pure allergic rhinitis, without asthma or without polyp, I don't see a role of combination. So pure antihistamine will work better without giving risk of the Montelukast, which is all neurological and psychological factors, especially in adolescents and young, even to the extent how certain small number of cases suicidal tendencies also been reported. But if the patient has polyp or if they have allergic bronchitis, I would say along with that, definitely we get better role.
To take?
Um, I think after so many years of using this combination, one has got addicted to the combination. But the point is, I have personally not seen anybody with a suicidal tendency. And I've been actively now asking patients, people who've been using this because they use it over the counter now, whether they're having depression and issues. So I don't think the percentage of patients having these reactions are probably very high. Having said that, a combination is not a good idea in any case. I think it's better to use them separately as needed. If there is asthma with allergic rhinitis, I think the combination has a place in management. But otherwise, I would be a little wary. In fact, they both have their advantages and disadvantages. An anticholinergic effect of an anti-allergic has a problem with increasing asthma. It has its own this thing. The cough sometimes increases with the antihistaminic. So I would probably want to give an anti-leukotriene if I have that feeling. So I
Dr.
think
Tiwari,
I would tailor
do you
it.
think what is the place of anti-leukotriene in management of asthma? Focused
So,
question.
again, sir, the basic, the sheet anchor of treatment is inhaled corticosteroids and then subsequently long-acting beta agonists. So these are just drugs which have an add-on effect you will give in patients who have, who require stage 4, level 4, level 5 treatment and who have comorbidities. So they're not our go-to drugs for treatment of asthma.
Particularly for asthma, what is the evidence, scientific evidence?
So, so the evidence is basically on some control of symptoms, and then there is some evidence that so in children that in mild asthma and patients who are not keen on taking inhalers, they have some benefit. But as such, they are not kind of drugs who will just change.
Dr. Vikram, what is your take on? We come to you because you are the best.
No, it's not like that, but very much agree with what he said. First line is always inhaled corticosteroid wherever, but there are situations where patients or their parents become adamant. Then it can be offered as a clear second substitute. It is inferior, but yes, this is something. Number two, when it came, it was, there was a lot of new hope because after so many years, this was the only new drug which had come for asthma and for allergies. Of course, it didn't live up to that, but it's not total rubbish also. When allergy is happening in the eyes, in the nose, in the sinuses, in the air tubes, where all will you keep pumping the inhaled corticosteroids? A little bit scope. And third and last is that in one third of the patients, and these are younger patients, Montelukast surprisingly helps. And this is proven that one third patients do well. 2/3 it is almost useless for asthma. Its trouble is to find out those ones. So it's not a great drug, but it's not total rubbish either.
So finally coming to the what Dr. Chavda was saying, that we should talk about trigger avoidance in asthma. What are the good practice points?
First thing is smoking. Unfortunately, I think we never discussed smoking throughout today's talk, but smoking is a very, very important factor in maintaining rhinitis and asthma symptoms. So that is first thing, both active and environmental tobacco smoke exposure at home. Second is the place where the patient is. Then the indoor environment, Dr. Matnagar had mentioned about that, so that we have to take care. Third is the external environment. Outdoor air pollution is something which you are very passionate about. We cannot do anything, and that's a long-term policy matter.
So I'm
But-
a gone case.
But some patients, I can tell you, I have personal experience, with change of residence, they feel better. So environment is a very, very important factor in management of asthma. And as far as possible, we need to identify factors which are contributing to exacerbations.
Before I answer this particular question, I have few points I'd like to mention about both those patients with poor control. We have not talked about immunotherapy. I would recommend even immunotherapy or maybe skin prick test or identifying the allergen. Number two, what I tell my patients that oral medication, antihistamine or Montelukast, though steroid, nasal steroid inhalers or sprays are better and safer. So if you are maintain on intranasal steroids, they are safer and better, not giving any dryness. Coming to his point of environment, yes, I always ask them, what do you do? Did you have any recent change in your environment, office worker? Recently, I have two patients of nasal polyposis. One of the girl I saw there before yesterday, she was working in a basement. So working environment very, very important, and they will say yes, then they will recollect, yes, I had a change of place or change of job and I started getting this. So this is anyway very important. Outdoor atmosphere, yes, I agree with Heather. All of us should work towards that. I also grow a lot of plants, they give allergy, but you can control your environment, you should work all together for that. Thank you.
So I think ENT guys like 2 points. Anyhow, the first observation was COVID. Wearing the mask dramatically improved allergic rhinitis and respiratory symptoms. Obviously, it has a place to play in our management, definitely. And now fairly acceptable. An anecdote, everybody was offering those. So I was working at a mission hospital in Okhla for many years, and um, endoscopic sinus surgery had just come up. And I just did, I mean, it wasn't a research, it was um, just a kind of a local research of some sort, which I did about 15 cases who had asthma with sinusitis, and the asthma dramatically improved after FES. So I walked up to my physician, I was very excited, and I told him, you know what, we should do more CT-PNSs, and I'm talking about really in 96 or 97. And we should do this and that. And after about listening to me for a while, he told me, are you coming to me because you want me to refer patients for surgery? And he just stopped referring patients to me. So there is a problem within the family on how surgery is viewed by a physician and how the excitement can be misinterpreted as somebody who's gunning to do a surgery.
No, we are not talking about that part, but science ki baat.
It is an opportunity to tell that.
So talking about science, there was a MS thesis done at the All India Institute under the guidance of Professor S. C. Sharma, who was head of ENT, and I was co-guide, where this first surgery we did in asthmatic patients. So it was a negative study. So when we actually did lung functions before and after, and the symptoms score. So just giving you I'm not saying what you are saying is wrong. So now I'm coming to Dr. Tiwari, one question. LAMA. Historically, 20 years back, no for LAMA for asthma. LAMA only for COPD. So what is the status in?
Long-acting muscarinic agents basically will come later on in the management of asthma. So basically, in as seen in step 4, step 5, and probably in patients who have asthma, COPD overlap, and also in those patients who are smokers. So these are the group of patients in which tiotropium or long-acting muscarinic agents will work. And then we have another group, which is, I mean, probably not a group, but acute asthma exacerbation. Maybe in that patient, you would give nebulization with both drugs, that is short-acting beta agonist along with anti-muscarinic to have a better FEV1 or PFR at 3 or 4 hours down the line. So these are the group of patients who will benefit.
So this
with
is the
that.
study which 2015, the addition of tiotropium leads to improved asthma control, improved FEV1 and PFR, reduced asthma exacerbation. Doctor.
Tiotropium is a useful drug for step 5 in patients who are already on a medium dose inhaled steroid plus LABA. So this is add-on. The first line management remains that combination of LABA and inhaled corticosteroid.
Yeah,
But
sure.
in patients who are not controlled, then this is a next obvious step available.
So we have to finish in next, yeah.
Off-label, we have been using for
A
nearly
very
3
long time,
decades
that's
now.
right.
But
So this continuing with the case, sir, we have to finish. So tiotropium, low dose theophylline and PPI were added. We're going back to the same obese lady, underwent FES for polyposis, still has partial control, needs low dose steroids for asthma control, not able to lose weight is following dietary modification but unable to do exercise due to shortness of breath. Serum Ig was 600 as I said. What else can be done, Dr. Tiwari? And what is the current status of biologicals? This is the last question that we are dealing with. I am coming between you and lunch, so yes.
So basically, sir, now we have kind of reached a stage where, as a part of our treatment, we'll need to offer her biologicals. Amongst biologicals, now we have 3 or 4 options available in our country. That one will be omalizumab, which will be anti-Ig therapy, and then subsequently we have interleukin 5 inhibitors in terms of montelukast, in terms of mepolizumab or benralizumab. So these are the drugs that we can offer. It will depend upon, for example, she has high Ig, and if we can demonstrate specific Ig or sensitivity to perennial antigens, then she will become a candidate for omalizumab. If she, as her eosinophil count was high, she also becomes a candidate for interleukin 5 inhibitor therapy.
So any experience on this? Have you
Um,
used omalizumab?
Sir, we have used omalizumab a lot of times, and recently now we are using mepolizumab for this subset of patients. These are the 2 drugs which are commonly being used, and then there was one trial in the institute on pharma-sponsored trial on benralizumab. So that also we have 15 or 20 patients of which
So
we have
our
experience.
ENT colleagues, do you use biologicals for your?
I haven't used them personally. There is some talk in the US in using them for a severe, a bad recurrent nasal polyposis, but I have no personal experience.
Dr. Chanchal?
Same here. I had few patients from USA coming. One of them had polyp, which recurrent polyp. He got better.
So
But-
Dr. Chabra?
it's now approved for patients with chronic rhinosinusitis and allergic asthma. That is one biological where it can be used.
So what about macrolides?
Macrolides are a weak option for patients whom we have done phenotyping and they are not candidates for biologicals. So there's some role that given thrice a week, these drugs have mild anti-inflammatory activity. So just last resort drug, but how effective? 250 milligrams thrice a week. At least 1 year, monitoring the patient for ear problem and sometimes ET.
So these macrolides have been used for bronchiectasis, for COPD as well as for asthma. We have been using it as a last resort. Immunotherapy we have partly discussed, but Dr. Vikram, would you use immunotherapy for this patient? You know all the.
I will not use it. I will not use it. See, immunotherapy works at the allergy level in this patient, and the more severe the asthma, the less reason to think and do immunotherapy. And contrast to that, the more severe the allergic rhinitis, the more reason to do this. So in this particular patient, because her asthma is severe and uncontrolled, I will absolutely not use it.
Okay. So there is anti-IL-4 dupilumab, which is Dr. Chavda has already. Anti-TSLP, that is tezepelumab, is not yet available in India, I think, but it's supposed to be a better drug and magic drug. And these are the, I can't go into this table for, this is just for information. So this patient was initiated on omalizumab. In this dose, improved symptoms over next weeks, oral steroids stopped after 3 months, no exacerbation for 6 months. So how do we decide? The last question. Which therapy is most likely to be efficacious in a given patient, especially in difficult to treat asthma? I'll ask only Dr. Chavda.
We have to identify all the factors which we have done in this patient. And all those, plus the techniques, compliance, environment, everything has to be tackled.
The future of asthma is that it is inflammatory lung disease, and towards the unified approach of inflammatory lung disease, and yet a personalized or precision medicine based on the phenotype and endotype has to go on. So I have a pleasant duty of, please give a big hand to my panelists, all the four panelists, and Vikram has been amazing. And let me confide in you that I am leaving this hall with more knowledge. I am not saying just for the heck of. Actually, I learned a lot from my colleagues and also my ENT colleagues. So many doubts that I had in my mind, which has been cleared. And thanks to Messer Sun Pharma for promoting this academic activity. And a big hand for special thanks to wonderful audience for being here. And thank you very much, and have a good.